So welcome everybody. I am delighted to be chairing today's session, HCV Action session, Hepatitis C Elimination Initiatives and Overview. It's wonderful to have you all with us here today. Already we've got, let me just see, already we've got 65 people, so this is fantastic. So just to give you a little introduction, in July 2019, a unique hepatitis C elimination deal between NHS England and 3 pharmaceutical industry providers went live, she says very quickly. As many of you already know, the elimination deal was a unique undertaking for NHS England, and it's been extremely successful in driving progress towards hepatitis C elimination, actually placing England as a global lead in the goal to eliminate hepatitis by 2030, if not earlier, with NHS England's 2025 target. This has really been and continues to be an incredible piece of work, and indeed an example of fantastic partnership working. So in this webinar today, we are going to explore this unique programme. We'll hear an overview of the backgrounds, how and why it came about, a little bit about the impact of the programme, and explore some of the key initiatives, including work being done in peer networks, prisons and drug services, and maybe a little bit toward, on the next steps as we reach near the end goal. So we hope that the webinar today will be particularly useful to any new colleagues that might be joining us today, working in areas such as primary care provision, liver health or other bloodborne viruses, and also for those of you who do work in it and perhaps just want to learn a little bit more about the wider elimination programme. There are many elements of the initiatives which may well not only benefit, but also could be replicated in other areas of healthcare, hopefully beyond this programme. So just before I move into the bits of housekeeping, this session today is really a bit of a precursor. So HCV Action will be publishing a report soon in early 2023, which will for the first time bring together a full account of the elimination deal and the elimination initiatives which we're going to hear about today. So just a little bit of housekeeping. Please, you're welcome, and please do type in questions into the Q&A or chat box or comments or anything at any time. We can answer them during the Q&A session at the end after the talks. And I'll try and pick up anything and try not to miss anything. We're recording the webinar, so it can be published afterwards. So for the speakers, just in case they didn't realise, it's a webinar format, so that in fact you can't see the audience, but I can tell you now they are all there in their drove. 88 of them are all there now. So please mute yourself if you're not speaking. And I think that's about it. We have some incredible speakers today, reaching far and wide across from delivery right from the top down. So we're going to start from the top down, and it gives me great pleasure to introduce you to Mark Gillyon-Powell. I haven't actually got your title here, Mark, but I think you're lead of the NHS England Hepatitis C programme. In fact, I don't know. In fact, I don't guess it. I do know it actually. So with that, as I'm mumbling, I'm just going to hand it over to you, Mark, so you can take it over.
That's excellent. Thanks, Rachel, and thank you for asking me to be involved today. I'm always pleased to talk about Hep C, so I'll apologise in advance if I go over my 10 minutes, but I'll try not to go over too badly. So really what I was going to do was set some of the context about the procurement kind of then and now, where where we came from and some of the background. So if we can move on to the next slide. That's great, thanks. So really what we did from the beginning, when we were starting to think about Hep C elimination, was trying to work out what's going to help us to deliver elimination in the best way possible across a whole system. One of the key things that we knew was that we wanted to engage with local clinicians. We wanted local clinicians to have some control and hand in designing designing their pathway in their local system, knowing their communities, developing the right kind of elimination initiatives and implementing those elimination initiatives. So we went out and commissioned, at the time it was 22 geographically based operational delivery networks, all led by a lead clinician and the majority from the very beginning with a program manager, an ODN manager, to actually do the business of developing the plan and making sure it was delivered. That's been really critically important, I think, in terms of us being able to get national ideas and national money down to a local level and effectively used. The ODNs have been kind of key to that. We then ended up splitting one of them, so we now have 23 geographically based, and we have one national ODN, which is our paediatric ODN, providing advice, guidance, support and treatment to individuals age 3 to 18. And that was the first one in the world, really, the first kind of specialist clinical network for children and adolescents with hepatitis C. So that's been really important as part of our delivery. One of the key reasons for going into the strategic procurement was so that we could develop elimination initiatives with the pharmaceutical industry partners, because we knew that there were skills within that industry around patient finding, marketing, and applying learning to pathways and reducing attrition that might actually help us with Hep C. So as well as us going to the pharmaceutical industry and saying we want a good financial deal on the medicines, we also said, and we want you to help us find all of these patients. That was a key part of the deal. And they came up with a whole range of elimination initiatives and funding for those initiatives to help us drive elimination. And the other key part really that we had to put in place was wide-reaching program partnerships. Obviously, one that everybody knows about and is very clear is our partnership with the Hepatitis C Trust. The Hepatitis C Trust peers are involved in almost every part of the elimination initiatives that are planned and delivered, and that's a kind of golden thread running throughout the program. But we also have had to do things like get really good partnership working relationships with people like His Majesty's Prison and Probation Service. We knew we wanted to go in and do things like prison hits and improve reception testing. We couldn't do that without having a close relationship with prison governors, with prison staff, being able to pay the overtime for some of those officers so that they could unlock people and move people around the system when we wanted to do testing and treatment. So developing those kinds of partnerships across government and across systems has been really important to mean that we can deliver. Okay, next slide. So what were the drivers with industry? Why did we go to industry? Well, at the time, and still, but less so, people were dying. We knew that there were a lot of sick people. People needed treatment, and more effective treatment was becoming available. So we were in a position where we were moving from interferon and ribavirin, rationed treatment, to DAAs, that we wanted to be fully available to everybody who was identified. At the time, going on the estimated prevalence of around about 135,000, the full cost drug price times 135,000 plus retreatments would have been unaffordable for the NHS in reality. It would have broken the bank. So one of the things that we wanted to do was, considering that prevalence and that we wanted to be able to offer treatment to everybody, considering the potential for escalating costs and our international ambition through WHO, but also our national ambition and our desire not to ration, we wanted this kind of deal where we would be able to afford to do everything that we wanted to and needed to do, and still be able to afford to find everybody and make sure that we could get treatment to them. Okay, next slide. So in terms of the scope of the strategic procurement, NHS England was committed to doing this. It was a huge piece of work. Anybody who was around at the time and involved in the strategic procurement, it might just be me and Graham, actually, I'm not sure who else is on, will know that this was a massive, massive piece of work. And I know it was for the pharmaceutical industry as well. But in terms of the developing those bids, but then the assessment of each of those bids was huge. We had 3 pharmaceutical industry providers who were already active and committed. They were already doing work in reality before the strategic procurement. And what we were looking for with them was a dynamic relationship that took drug price, elimination initiatives, and some funding, and giving us the skills that we wanted in the system from them. So we went through this process where different industry partners put forward different elimination initiatives that they wanted to run with. So Gilead, for example, identified prisons and drug treatment providers. MSD identified point of care testing. AbbVie identified point of care testing and some other pieces. So we had this kind of shape of what we wanted, and then each provider was awarded basically a share of the market based on all of those things: the drug price, the money they were going to put in, and the elimination initiative. So they were awarded a share of the market, which basically meant that we removed any degree of competition really between those 3 organizations. So it didn't matter which organization went into which ODN area, because they couldn't sell their own drug. They were actually just trying to expand the market so that their market share went up with the entire market. So each supplier has specific but flexible elimination initiatives, and they were allocated at the time to specific ODNs. There wasn't really anything that was for every ODN. There were 1 or 2 things like the AbbVie oral fluid testing, but most things were allocated. So it was, these 6 ODNs are going to have this, and those 5 ODNs are going to have that. There wasn't anything across the board. Okay, next slide. And this is what we turned it into. So people will have seen this before. You might not be able to read all of the writing on it, but basically what we realized was that, as an example, Gilead's partnership with KUK, as it was then, PPG now, would cover 46 prisons. Well, we had another 60 prisons, 60 odd prisons that we needed to provide the same level of service in. So everywhere that wasn't being covered by that Gilead elimination initiative, NHS England then took on the responsibility for that. So we made it so that all of the major elimination initiatives were across every ODN. They were universal. And then we introduced a load of others that that NHS England were particularly interested in or that developed over time. Okay, next slide. So I can never let people let an audience get away without pointing out what we've achieved so far, because this is really magnificent. And this isn't what we've achieved in terms of NHS England. This is what we've achieved as a group, as a country, as a whole range of partners. So the number of people living with chronic Hep C in England has fallen dramatically since 2015. So I think at the time we were looking at in excess of 130,000. We're probably at about, even by official estimates, we're probably at about half that now. Measurement and estimated prevalence is difficult. So, some people believe there may be less than that. Some people believe that that's okay. But either way, what we know is incidence of infection, the number of people living with chronic infection has fallen dramatically. And that's partly because of these things. So 102% increase in testing in drug services, which is amazing, an amazing turnaround from where we were. 140% increase in the number of people accessing treatment. we've now treated over 70,000 individuals. So just so that people are aware of that. 37% reduction in deaths from Hep C, and this is 2020 data. So this will have developed even further since then, and a 52% reduction in the number of liver transplants, and that's the number of liver transplants that was specifically in relation to Hep C. So that's for every individual that no longer needs a liver transplant. That's a huge win anyway, in terms of the trauma and the lifelong consequences of that. But actually, aside of that, that amazing thing, it's a liver that's left in the system for somebody else. It's not like we've got spare organs. So actually, by doing this program, it is helping across the entire NHS. Okay, next slide. So what next? I've talked about some of the elimination initiatives that we started with, and we've made significant progress with those, and some of them are continuing. Things like the drug treatment services and prisons and so on, all continuing to go in, patient find, and get people into treatment. But a real key focus now is about the people who are unaware that they might have been at risk, or who may be asymptomatic, or who maybe don't want to access mainstream services, or wouldn't want to talk to their GP about Hep C. We wouldn't think to go to a sexual health service or a drug service and get tested. So we're trying to look at places where we can just kind of opportunistically catch people. So antenatal screening we're planning to have in place across England from the 1st of April. That's taking some significant work from my team, and quite a lot of fighting to get that prioritized for the system, but we will do it, and we will have it by the 1st of April. By hook or by crook, we'll do it. Emergency department testing, people will have heard of, and hopefully you've seen the first 100 days report that came out about the ED testing, opt-out testing in London. Massively successful program, also rolled out to Manchester, now rolling out to Blackpool and Brighton, and we're just now looking at the business case and the finance for the next 30 areas to target for ED opt-out. So we're finding significant amounts of new Hep C and HIV, but also individuals who have been lost to follow-up that we can get back into the system, but finding double that in Hep B. So really important that we can kind of get that rolled out. Significant amount of work taking place around primary care, so people potentially with historic risk factors, and the only health service that they see potentially is their GP. And the other thing that we're just about to move from alpha phase to beta phase with, ready for rollout from the 1st of April again, is the at-home testing portal, so self-sampling web testing. So individuals go on and order a test, very much like the NHS England, NHS COVID site, for any of you that have been on there and ordered a test. And the kind of early versions of that are looking great, and that will be an antibody test followed by reflex PCR for anybody who orders online, available in English and Urdu, and there will be both universal and targeted media campaigns to get people to come forward for self-sampling and at-home testing. Next slide, please. This was just really and I'm towards the end now. This was the week last Friday. We had an NHS England board, the public board, so the one that's videoed and goes online and everything else. And one of the things that they specifically wanted a briefing on from the chap on the slide, John Stuart, who's the National Director for Specialised Commissioning, was where medicines policy had made a big difference to delivery. And one of the main things that he talked about was the success of the Hep C programme. So this is NHS England's board talking about the major success from Hep C elimination, and that came out as a press release as well on the 1st of December about how we were racing towards elimination, really, and that we would do it in advance of 2030, and then it was at the board on the 2nd of December. Really, that's just to point out to you that this is absolutely at the top of NHS England's agenda still, and will remain so. The chief exec of NHS England gets briefed on how we're doing with the elimination programme. It's a part of our long-term plan, and it's not going anywhere. It's certainly, going to remain as one of the key planks, key success stories that Amanda, the chief exec, will keep returning to. And I think that might be it, but if you press the, yeah. So I think that was everything I had to say. I don't know if you're doing questions now, Rachel, or if you're doing them later.
We're going to do them at the end so that we can
Yep.
have all the presentations. Are you all right? Are you okay to hang on and to be
Yep,
around still? Brilliant.
Absolutely.
Thank you so much, Mark. Incredible. It's just incredible. I'm really thrilled to hear that it's still on NHS England's agenda and it remains high. Swiftly moving on those, I'm going to move over to Graham, Professor Graham Foster, who probably needs no introduction. So Graham, over to you.
Rachel, thank you very much indeed. Always a pleasure to chat to colleagues. And my highlight from today is really to talk about the needs assessment. Many of you in the audience will know only too well what the needs assessment means. It means an awful lot of hard work. It means wandering around, testing, and we've done brilliantly. Although not quite as brilliant as our slide mover. Could we possibly go back, please? We're getting all overexcited here, and I can understand why. But I do want to start by thanking everybody in the room who has contributed to this extraordinary performance. The basic principle of the needs assessment is we want to know how many people are left with hepatitis C to treat, because the focus that we have to have over the next year or two is to mop up. We know, as Mark's just explained, that we've made enormous progress eliminating hepatitis C. The question we have to answer is, what is left? Where do we need to put our energy and resources? And the needs assessment was aimed at what we still believe is the most important group, which are people who are actively or have recently injected drugs, because they're the people who are likely to be transmitting the virus. And we want to stop the transmission as quickly as we can. There's a whole different phase of the programme looking at people who injected drugs many years ago, people who perhaps had blood transfusions, perhaps acquired hepatitis C abroad. And that's a programme that really will be addressed by primary care initiatives. Mark spoke a little bit about some of those, the antenatal testing, the testing in emergency departments, the web-based portal that will allow us to encourage people to seek a test without going through their primary care physician, without contacting healthcare professionals. But that's a different population of people that we're focusing on over the next couple of years. So what I'm going to do is recap where we are in testing and treatment in people in addiction services. Next one, please. And the answer is the fireworks are up. We have hit our targets. Do not underestimate how challenging it is to find and test 11,000 people over a 6-week period, get all of their data, everything documented, get all the results given out. And although we're still not quite finished with all the results, you can see from this chart that we have really hit our targets. We've tested over 11,000 people, and that is a fantastic achievement. It's something that no one else has ever been able to do. It's a real-world assessment of what is happening in addiction services. Next slide, please. So this is the drum roll. This is the prevalence of hepatitis C in England in people who are engaged in drug services. And you can see it's less than 7%, an extraordinary number when you think that only a few years ago it was in the 30–40% mark. This is a massive reduction in hepatitis C in people who are in the highest risk category. So we have made extraordinary progress. What you can see is that there is a little bit of regional variation, and that's to be expected. Inevitably, when you start a program like this, there will be people who, early adopters, perhaps with a low prevalence to begin with, who can make progress very quickly. And then there are some very large addiction service networks. And it's no surprise that the biggest networks, that's Northeast, Humberside, Birmingham, the geographically most disparate organisations with probably the largest populations, have been a little bit slower to make the progress that some of the smaller networks have been able to achieve. But it's worth pointing out, of course, that even in our poorer performing networks, they've made substantial reductions. This is probably at least 50% of the proportions that they had 5-6 years ago. So we really have made huge steps in eliminating hepatitis C in this population. What's important to see is that although we've brought the prevalence down, there seems to be a flaw. Most people, no matter how hard they try, are sticking at around 4 or 5%. And I think that's real. We're a free society, we're a free country. We can't force people to have hepatitis C tests. We can't force them to take treatment. And there will always be people who decline to be tested, who decline the therapy. And we're certainly not going to force those people into having something they're not comfortable with. So I suspect that as we start to move forward, we will be left with a small population of people in addiction services who have hepatitis C. And the challenge that we now have to address is, how do we keep that number down? How do we stop this virus spreading out from a very low number into a much larger population? And that's going to be the challenge ahead. But that, compared to the challenge of treating 30-40% of patients, is a much easier ask. Next slide, please. Now, this looks at a slightly more subtle approach to the number of people who have hepatitis C. It breaks it down by people who agree, who tell us they're injecting drugs, and people who tell us they're not. And the things that highlight here are that clearly the prevalence in people who say they're injecting is a little bit higher, around 10%. But in people who are going into addiction services, around 2% have hepatitis C. So that tells me that we need to be broadening our net. It tells me that just focusing on injectors is perhaps not the right thing to do. We need to be testing everybody. And that's clearly going to be very important as we move forward. Next slide, please. When we looked in the needs assessment, we looked in different areas. We looked in people coming into addiction centres, people in structured treatment, and then people outside, people who had much less engagement with structured treatment. They were in needle exchange programs, they were street homeless, etc. And again, what you can see is the prevalence rates are lower than we expected, which is nice. But in people who aren't engaged in addiction services, the prevalence of hepatitis C is around 13%. And one of the things we're now doing is looking at the data in much more detail to try and work out who are the people most at risk. And the early hints that are coming through are that it's people who are temporarily homeless. So if you don't have a home, if you're street homeless, your prevalence of hepatitis C seems to be much higher. And that's really important for us to know and to understand, because it tells us where to focus our efforts in the future. So what we're going to have over the Christmas period is a real drive into people who are street homeless. As you know, during the cold spells, there are extra facilities. During the Christmas period, there's a little more sympathy for people than there is normally. So that allows us to have targeted testing in food kitchens, in shelters, etc. So we hope that we can start to attack this homeless incidence of hepatitis C and bring it down still further. Next slide, please. This for me is the most exciting and the most important piece of information, because one of our targets is to stop hepatitis C being passed on. Now, if you've just caught hepatitis C, if you've never had hepatitis C before, for the first few weeks, you won't have any antibodies against hepatitis C. You'll just have the virus in your circulation. So you'll be RNA positive, but antibody negative. And those people are not normally tested for in that way. It's not something we usually look for. But we did this as part of our massive needs assessment exercise. And you can see on this slide here that we found a few people who had been very recently infected within the last few weeks. And if you do all of the figures and multiply up, the incidence, the number of new hepatitis C infections is about 1.5 per 100. The WHO guidance is to get that below 2 per 100. And the reason WHO picked 2% of new infections was because mathematical modelling suggests that is at a level that will not allow the virus to take off and spread. Now, that's a model, and I'm not sure that all of us would agree with that 2% figure. But what this data shows is that we have done spectacularly well in stopping new hepatitis C infections. And that is a huge goal for us, because it does mean we're well on our way to eliminating. There's one tiny caveat here, and a very important caveat, and that is that people who have had hepatitis C, cleared the virus, and then got reinfected won't be detected using this testing method. And what we know is that the reinfection rates in people who've had hepatitis C is about 3 to 5%, much, much higher than the WHO target of 2%. So one of our focuses over the coming years is going to be on people who've had hepatitis C treatment, got rid of the virus, making sure they don't get reinfected. We need to ramp up the harm reduction messages, make sure we've got better provision of needles and paraphernalia, and do all that we can to stop people getting reinfected, because that is a really important target for us. All of our good work is wasted if we allow this virus to take off. And rather like COVID, you see the amount of virus going down, and then you take your foot off, you take your mask off, and suddenly it goes up again. We really don't want to see that with hepatitis C. These data tell us that we're well on our way to stopping the spread of hepatitis C. But please, for those of you out there dealing with people who've had hepatitis C treatment, we need to make sure they don't get reinfected, because that's the Achilles heel in the program at the moment. That's where we need to focus. Next one, please. Again, this is data confirming just how much progress we've made. These are the proportion of people who have antibodies, but they don't have the virus. They're the people who've been cured of hepatitis C. When we started the program, we expected it to be about 20, 30%. You can see it's now heading up to over 70%. So huge improvement. And this is due to treatment. This is due to the work that you and everyone else has put in, finding people and getting them treatment. Most people you see with hepatitis C positive antibody tests now don't have the virus. And that wasn't the case 5 years ago. This is what we've achieved in the treatment program. Next slide, please. So my message is we are making extraordinary progress. We are clearing hepatitis C in the community. We need to focus on people who are homeless. They're a group that we haven't done enough work on, and that we'll put right. We need to focus on stopping infections in people who've cleared the virus, and that's a real focus for us over the next few years. And then finally, we need to shift this good work into the community and find those people in primary care who've had hepatitis C and still haven't managed to get into the treatment pathways. But I just want to finish by saying a huge thank you to everybody involved. Stuart, very appropriately, is next off, because Stuart and his team played an absolute pivotal role in getting patients into the needs assessment and telling us where we are. And of course, Stuart and his team have been absolutely pivotal in getting out into the communities and getting people cured. So well done, folks. It's working. We're winning. And thank you. Rachel, over to you.
Thank you, Graham. That was amazing. It's great to see some results on that, and absolutely a massive piece of work. I know you've got to go, so I just wanted very quickly, there's a couple of questions that have come up for you. I wondered if we could very quickly do them, because I'm going to throw the timing out on the format. But there's one of them was, when do we get the results back from the needs assessment?
It's a great question. We're nearly there. We've got about 85, 90% back. We're still mopping up. There's still a little bit of work to do on some of the formatting of the results. So everyone will get their individual results as a profile, and then we need to produce a final report. And the final report requires a little more data digging. What we haven't got yet is all the information from all of you out there saying who was a homeless person, where did you test? We need to just pull that together. We hope we'll have a final report by January, but if you have results that haven't come through yet, we are expecting those within the next few days.
Brilliant. And hopefully these slides serve as an initial starter of some of the results anyway. Just one quick question before you go, because it's really interesting. Will there come a time when HCV Hep C infected patients will have a PrEP-like medication pill to take? What do you think?
I think it's a brilliant idea. And I think, yes, I can see that happening. What we've got to do is get the price down. And when we can get the price down to a sensible level. But I think my message perhaps is that whilst we're waiting for all wonderful new drugs from the pharmaceutical companies, etc., let's do the simple things right. Let's make sure everyone who's using drugs has an opportunity to get as many clean needles, as much clean paraphernalia as they need. Let's remind people of the importance of good healthcare in their injecting practices so that they don't catch hepatitis C. And of course, they don't get other infections. They don't get all the terrible consequences of dirty, contaminated needles. Let's keep our people safe.
Yeah, and just finally, right on the end of there was one that you said you'd like to answer live, and that was with your home testing. Are both tests on one sample, or is a follow-up for PCR required? So I know the answer to that. Do you want to quickly answer that before you run away?
Really important that when we do the home care testing, we're going to find out who's got the virus, and then we are personally going to make sure that the networks contact those patients directly. We're not going to leave people in limbo land saying you might have Hep C, you might not. It's a bit of a worry. We're going to phone people up and say we've done Hep C antibody and RNA test on the sample. You definitely have Hep C, and here's how I'm going to make sure you get treatment. We're not going to leave people in limbo land. We're going to fix this once and for all.
Perfect. Perfect. Well, Graham, thank you so much. Really appreciate you being here, and sorry you can't stay till the end. But as you so eloquently said, I'm going to swiftly move on now to Stuart Smith. So Stuart's the Director of Community Services at the Hepatitis C Trust. He's actually sat beside me here, who's going to talk about the peer programme and their role in the community healthcare, particularly specifically within the Elimination initiative. Stuart, over to you.
Thanks, Rachel. Thanks, Graham and Mark, for your talks. And I'm aware that there are people here who know our peer programme and work alongside them, or even deliver them. And there's also people here from the wider reach of healthcare. So this is going to be a top-level talk about our peer-to-peer programme as delivered as part of the elimination initiatives that Mark alluded to in his talk earlier. And I just want to quickly say that it's thanks to a lot of the people on this webinar and all the healthcare teams that the peer programme has been able to flourish and really deliver the outcomes that it was designed to do. And it's done that because of fantastic partnership working from everyone involved. But essentially, most importantly, I think, is the clinical teams themselves. So the healthcare in the hospital have actually made our peers part of their team. And where they've done that, and they've seen our peers as an essential component in the healthcare of the people that we work with, that's where it's really worked really well. So if you can move the next slide, whoever's in control of them. Okay, so essentially we can split our peer program into three core parts. And in fact, awareness was the original program. It was designed in the days when treatment wasn't the best option necessarily. You had to really think about whether you wanted to go through all the treatment. It didn't have a great success rate. But the peer program was designed because we knew that we needed to make people aware that there is a virus called hepatitis C, and how you can catch it, how you can keep yourself safe from catching it, and how important it is to get tested. Because if you have put yourself at risk, it's important to understand that you've got a disease that's potentially doing damage to your liver unbeknowingly to you every day until it's often too late. So awareness was a big part, and we realized that we were working predominantly with people who affected by substance use and homelessness, and sometimes healthcare professionals, the police, other people of authority in their lives, teachers maybe, whoever that may be, had not really got through to them about some of the issues that we wanted to talk to people about, and we realized that by recruiting people who had been in the same place, so we call that lived experience or even living experience, then you know, we get a response. We get people suddenly look up and listen and take in the information they're being given by a different route. So awareness and testing is still a big part of the work we do. We go out and deliver workshops or events, and we engage people. We even share that we've been where they've been. We share a cup of tea and a cigarette maybe, and get a conversation and start to build up trust. And in that conversation and trust building, we're able to deliver really important healthcare messages to these individuals. The support to treatment part, that really came to light with the advent of the new direct acting drugs, where we jumped overnight generations of medication. We went from a really poor sort of therapy option if you've got hepatitis C to an oral, very successful cure overnight almost. And that was a game changer. And in fact, as Mark alluded to, the Elimination deal came along. All of the timing fitted very well for the peer program to start testing whether it could really make a difference in engaging people and getting them towards treatment. And I'll talk a bit about that in a minute. And then crucial to our work has been our volunteers. So we have over 100 staff dotted around the country. We are in prisons as well. We are connected with every lead hospital, of which there's 24, Mark alluded to earlier. We have programs in Scotland and Wales as well. But although they are staffed by 1, 2, or maybe 3 or 4 individuals at each region, it's the volunteers who are really paramount to the success of this program. And they are often the ones with much more living experience than even our staff, who are mostly 80% probably have also had hepatitis C. So next slide, please. So I've talked already about the awareness raising, myth busting. There's old information. When we move from the very old, difficult to tolerate treatment, that got left around like a residue of information amongst people on the street, amongst people using drugs, and they would, you know, the message was don't go near treatment, it's awful, and they were quite right, but actually treatment had changed. So there was a big agenda really to get that message out to people so that they weren't scared of treatment, and for them to understand that there's hardly any side effects associated with the new treatments. Addressing stigma is a really important part of our work. We would go into drug services and there would be groups full of alcohol clients, heroin, cocaine, bit of everything. Sort of, we would, regardless of who we talked to, we talked about hepatitis C, so that you know, it was brought out into the open and people didn't have to hide behind, you know, a diagnosis of hepatitis C. The extended reach that we offer is beyond even drug services, beyond healthcare, beyond Salvation Army, food banks. We're able to really go out and we often do home visits, and you know, the whole premise of the peer program is to reach as deep as we can into the community of people who are not engaging in traditional healthcare routes, and then influencing the care pathway. And that was another game changer for the peer program, and much more when we were really able to embed ourselves into NHS models of care. I think essentially the big barrier was that people who are homeless or affected by substance misuse were told to go and see their GP. The GP, being the gatekeeper, if you like, of secondary care services, would then maybe create a referral into a hospital. There would be an admissions department somewhere in the hospital that dealt with admissions for all the departments, who would send a letter saying in 3 months you've got an appointment in this hospital. and nobody was making it through. And I mean, the DNA, so did not attend rates, were 80% plus for many of these hepatitis clinics that were put on by healthcare in hospital settings. And we sort of made a promise that we could fill these clinics, but not if our client group had to go through all of this sort of hurdles to get there that didn't work for our client group, if you like. And, you know, there is something about equity of access. And that means, you know, that we do have a responsibility as healthcare providers to make our services accessible. And although my mother could keep a diary and she would be at hospital in 4.5 months' time on a certain date, we were working with people who had a lot of complex issues going on in their lives, a lot of chaos, and you know, those long drawn out pathways of appointment over here, then appointment over there, you'll get a letter, maybe you've got somewhere to receive a letter, maybe you haven't, just wasn't working. And what the clinics did for us in secondary care said, you can walk people in if they've got hepatitis C next Thursday afternoon. We're doing our clinic on Thursday afternoon, just walk people in, and we will see them and assess them for their hepatitis C and their possible treatment. So that was a big change for us. And, you know, it's notable in that doesn't exist outside of, well, I don't understand. I'm not sure. I've not heard of any outside of the hepatitis C field where you can just walk into a hospital and see a specialist service and start discussing treatment. But it's made a very big difference to the peer program, and it sort of extends the hospital reach into the community and allows us to engage people and bring them in. Next slide, please. So some of the things that have happened over the lifetime of the peer program are talk and test. Very quickly, I talked earlier about our workshops where we went in and delivered talks about hepatitis C to people, specifically in drug services. And our peers turned around to us and said, look, you know, if you had someone testing at the end of the workshop, everyone seems to want a test after I've gone in and told them about my hepatitis C. So we put that in place, and overnight we turned around the testing numbers in drug services where we tried it, who were struggling to get people tested. We were able to get like 80 or 90% of the people in the workshop tested at the end because of the power of the peer story. The follow me I talked about just then, that was when we were able to get those sort of open slot golden tickets to just walk into secondary care. So the idea being is we could meet someone in the street, we identify they've got hepatitis C, and we could say, follow me tomorrow or next Thursday, I'll meet you at the bus and we'll go to the clinic together. So that was the creation of the Follow Me program. The open slot clinics were sort of the backbone of that program, if you like. So the idea was, follow me, there's an open slot next week and I'll take you there. Since then, some of the add-ons that have been really that are starting to come into fruition are the mobile outreach vans, and we have one van that's driven by peers, and there's fiber scans delivered by peers, there's Cepheiad RNA testing delivered by peers, and they're very successful at engaging people who we, you know, for sure would not be able to engage unless this was peers delivering this service. And obviously we replicated the model, and I think all of the prisons now have access to peers who can walk the wings. There's a lot of big high intensity test and treat programs that happen, and I think the peers have been crucial in being able to do whole prison testing over the lifetime of the Elimination project. So next slide, please. I'm sure I'm running out of time because I'm bored of my own voice already, but this is a map of where the peers will engage with people, and as you can see, it follows them all the way from testing to cure. And peers hold their hand all the way through that process. I'm sure the slides will be delivered out to everyone attending today, so you can have a little bit more time to look at those slides. So next slide, please. We have a very modern mobile phone app that allows our peers to support patients, it says what they did with the patient, and then it says what you're doing next with the patient, and then they have reminders. Don't forget Sarah's going to the clinic with you today. So it's like a patient management system that we give to our peers. I've just shown that in what it looks like on a phone, just for the sake of you guys today. Next slide, please. We can skip this slide. It's a little bit old data. It shows that we engage an awful lot of people every year. Can we go on to the next slide? And so these are our treatment numbers. And actually, you know, the one thing I love about these graphs is that actually out of the people we find who are actually in orange, and then the people who get treated, you know, that is a big turnaround from the old days where we found a lot of people, but none of them engaged with treatment. So that's, you can have a bit more time to digest that slide when they're sent round. And then next slide, please. I'm sorry if I'm rushing. And since we began Follow Me, we have directly supported, it shouldn't say almost, because it's an exact number that I dug up about half an hour before today's webinar. So 7,244 people have successfully gone through treatment being handheld by our peers. And then the next slide, please. Hopefully it'll say thank you. So a few bits of feedback. This is a bit of feedback from a clinician in South York. He's actually the ODN clinical lead. And, you know, this is another example of that real joined together partnership work where it's been so successful. And in fact, in that hospital, our peers are part of the MDT, so the multidisciplinary team who get together and meet to talk about initiating treatment for someone. And that works really well. So next slide, please. And I think we just got a final bit of feedback from a patient. And so I will leave that slide on for you to read. And then if I stop talking now, Rachel, who's sat next to me, won't be so upset. So I'll leave it there. Thank you.
I'm not upset. I just think that I always think that we're going to run out of time, and we do run out of time. Such a shame. Thank you so much, Stuart. It was a really good overview of the peer program. Brilliant. Really.
And
brilliant.
I'll just quickly say, Rachel did not say once, hurry up. I just felt it in the room.
Yeah, thanks. But the best way that we can possibly move on from there is to have, we've got Zoe Yates, who is the peer program manager in West Sussex, or not West Sussex, in Sussex, should I say? Sorry, Zoe, who's going to give us a very brief overview of the work that she does on the ground as a peer support worker. Zoe, over to you.
Thank you, Rachel. Firstly, I'd just like to say that I felt really proud to be I always feel proud to be part of the Hepatitis C Trust, but more so after listening to Stuart going through his slides. It's something that absolutely blows me away and something that I love doing on a daily basis. Why is it effective? I think as peers with lived experience and our amazing volunteer peers is, we know where our clients are. We have experience of feeling what our clients are feeling, and we're able to think outside the box as well and support our clients in removing any barriers they may have to support them to access treatment. Alongside that is, one of the things we never do is we never give up on our clients or patients. Someone might not be ready to access treatment in that moment when we're there with them, but we will continue to reach out to them on a regular basis until they are maybe at the point where they are ready to access treatment. And what I thought would be really nice is to be able to share some examples of the work that we've done in Sussex. But Stuart also touched on something. When we first set up the peer support programme in the Sussex area, is a huge thank you to the Sussex ODN clinical teams, because they really reached out and really included us within their teams. And I truly believe that the work that we've managed to do over the last 3 years would not have happened if that wasn't the case. So some examples that we've got, soon after I started, we went quite quickly into lockdown, and we had to sort of like think outside the box, something we do really well, and think, how can we still support our clients as we were coming out of of the lockdowns. And one of the things that we set up in Sussex was, I call it the Deliveroo service. So it's where we were taking dry blood spot tests, so finger prick test for people that wanted a test for hepatitis C, or for people that have completed treatment and needed an end of treatment test. So the Deliveroo service was where we would drive to somebody's home, stay outside in the car, the client would come out to the car, we would talk them through the test, they would go back indoors, and we would wait in the car until they completed the test. And something that come out of that is 2 clients that I was supporting. So one client that I was supporting access treatment, he'd been living with hepatitis C for a long, long time, and we managed to get him to his first appointment and he started treatment. In the block of flats where he lived, he had a friend that he was also using substances with, and somebody that needed to have a hepatitis C test. And as a result, we were able to use the Deliveroo service to test to see if he was positive for hepatitis C. And he was. We was able to quickly link him into the open clinics and get him started on treatment. So these 2 clients I named as the men on the wall. The reason for that is because they only needed 1 appointment with the clinical teams. Everything else was done by the peers in the area. And literally we would go up and pull up outside their block of flats. We would bib the car and they would both come down, and we would sit on the wall outside their home and have the conversation to check in with them. We'd deliver their medication to make sure that they were okay. I'm really proud to say that they both cleared their hepatitis C and they felt fully supported all the way through. Another reason on why it's really effective is so me and one of our peers, Lee, we went over to the emergency accommodation project over in East Sussex, and we done like a Hep C testing event. And there was a patient there that they come down to see us, and me and our peer Lee actually knew him from Brighton. So we'd been placed out of area. He come down to see us and he let us know that he had been sitting on hepatitis C treatment medication for over 4 months. So he was prescribed this medication from a different area, and he moved to Sussex and he sat on that medication and he just put it off on a daily basis. I'm not going to do it today. I'm not going to do it today. And me and Lee were able to have an open conversation with him. The first thing we done is we asked him to check that the expiry date was still okay on the medication. And then we talked him through our experience of having completed the treatment. The next day, I received the loveliest text on my phone, and he told me that he had started that medication. And he told me the reason he started that medication was because when myself and Lee had told him that the treatment was okay, he believed us. He told us that when the nurse had told him that the treatment was okay, it was something that he thought the nurses said to everybody. So again, the value of that peer support and using our lived experience is, yeah, undoubtedly absolutely amazing. And then just this week, me and another peer of ours, Becky, we were over in one of the homeless day centres, and a client come in, and you could just see, you know, like, I hold my heart as I say that, you could just see that he felt really shameful. And the reason for that is because he come in for a test and he told us that he had this abscess on his leg that hadn't been dressed, and he was really aware that the abscess smelt, and he asked us if we could smell it, and we just replied, "We've been where you are." And you could literally in that moment see the relief on his face and the shame he felt gradually disappear. That is why we do what we do, and I love being a part of it. I think I'm going to leave it there.
Thank you, Zoe. That was amazing. Fantastic to hear from you and to hear how it works on the ground. Incredible pieces of work, incredible. I'm just going to quickly move on because, as I said earlier, I'm not kept to a timing in any way whatsoever. As Stuart alluded to, as did Mark, that we also run peer programs in prisons, and peer and do run partnership projects, I should say, in prisons. So I'm delighted to introduce you to Lee Christensen, who is the Hepatitis C Trust National HIT Manager, Kate Corns, G4S, Head of Residence in HMP Oakwood, and Christine Baggett, Practice Plus Group Lead for HMP Oakwood. So the three of them are going to talk you through some elimination initiatives in prisons, including the high intensity test and treats. Lee, over to you.
Okay, thank you very much, Rachel. Can I have the next slide, please, Zoe? So I'll briefly introduce the first couple of slides, and then Christine and Kim will do it. So HMP Oakwood is one of the biggest prisons, if not the biggest prison in the country. It's by far the biggest hit that we've done so far, in partnership with Practice Plus, the healthcare provider, G4S, the prison service, NHS Birmingham, and Gilead Sciences. So the HMP Oakwood is a Category C prison based in Wolverhampton, and when we done the hit, it was held 2,099 prisoners. I think the biggest one we done prior to that was 1,200, 1,500. Next slide, please, Elliot. So a hit, high intensity testing treat. It's sort of like a whole prison testing program. We go in with the aim of testing as many of the prisoners as we can. We always aim to try and get over 95% and get over 90% of those who need treatment onto treatment. Initial HIT plan starts normally about 5 months. So we'll go in, we normally have our first meeting face to face and get all the partners on board. I mean, go in and meet the director or the governor. So me and head of healthcare, local commissioners, ourselves, and Gilead. Do you mean to go in and give them a brief overview of the HIT elimination program from NHS England, what it is, how we'll do it, and why we're doing what we're doing. And it also gives us a plan, an opportunity to look at the prison, look at the geographics of the prison, and sort of gives us an idea of how we can plan the testing event out. So the initial thing that we like to do is get the date set for the HIT. Normally plenty of time. We normally have like a 12-week build-up process towards a HIT. It gives the hospitals, the healthcare, everyone an opportunity to clear the diary for that week for the HIT. And what we'll do off this, you know what I mean, because I think we're running out of time, I'll make it brief. We'll send you the HIT toolkit that will give everyone a step-by-step look at how we can implement the HIT. We also look at, so we get the date set for the HIT, we look at what testing kits we're going to provide, and we've explained the incentives. So like incentives get used out in the community, so we didn't want to discriminate anyone that was in prison, so we agreed that we needed to also, we don't call it an incentive in the prison, we call it a purpose activity payment. So sort of just gets them in, so the guys get exactly what people get out in the community. We also look at then how many testing teams we'll need. A testing team consists of someone from the Hepatitis C Trust, a prison officer, and a nurse to do the initial antibody testing. We then have a follow-up testing team that will do Cepheid testing and start the treatment pathway process. We also need to look at how many staff, how big the prison is, how many prisoners need testing, and how many staff we need to support the HIT. And we need, ideally, we always try and get the prison officers to be dedicated to the team. You know, it's a prison environment, anything that can happen in a prison, but the prison team stay with us. And Oakwood were fantastic, you know what I mean? So we decided we needed 2,000, it was the biggest hit we were going to do. We decided we need 8 testing teams, but we knew it was like staffing levels in the prison, it was going to be hard to get 8 staff dedicated to support the HIT. So we agreed that we'd have 4 staff from the prison, and we'd split 1 staff member between 2 testing teams. In the case of Oakwood, all the wing staff, everyone in the prison wanted to be involved, so we were lucky that we had staff support on every team doing it. G4S agreed on how the regime would run and looked at like locking it down. The 3 main wings, house blocks, all consist of over 600 prisoners per house block, you know what I mean? Locked into 2 lowers and an uppers with 2 landings on each. So we had with 4 spares on each, so we had like 2 teams going on to each spare, and worked around the regime. So we look at going on the lowers in the morning, and the director agreed to lock them down, so we go door to door to do the testing. Once we completed that, we'd then come out, have a bit of a briefing and a debriefing, and then in the afternoon we'd then go on to the uppers. and clear that wing. And then the follow-up team would then come in and arrange to do any ongoing separate testing. All actions for each team are agreed and further meetings. So we normally start our meeting process off with 1 meeting a month. That'll then drop down to fortnightly, and then as we're coming into the last month, we'll get them meetings on a weekly basis just to make sure everything's in place for the hit. Next slide, please, Elliot. So hepatitis C trust and peers, we've got lived experience. Our gold standard is to we have prison peers that our regional coordinators will train up in each prison. We had some peers trained up in HMP Oakwood. Sometimes people get transferred and people get released who've been trained up to peers. So then we look at like recruiting healthcare reps, prison information guiders. Do you know what I mean? So we deliver hepatitis C training awareness to all our peers in the prison, staff, prison officers and healthcare. So everyone's given the same consistent message out. So then, and we attach each prison peer is allocated to a team and sort of becomes a part of that team for the whole process. We always look to try and get as most diverse cohort of peers as we can to support the hit. And in this case, it worked extremely well. The attendance, FC Trust attendance, HMP Oakwood should put out comms. So we look at every avenue for comms. I think for HMP Oakwood, we had Oakwood TV. So some of us went in and done like little interviews, question and answers, and we put them out on a weekly basis on the 4-week build up to the hit. We also deliver leaflets under everyone's door, telling all the prisoners exactly who we are, what we're doing, why we're doing it, and what they'll get for doing it, and when we will be on their wing to do it as well. We also use the kiosks. We put posters up. It's sort of a really big process of build up. So everyone's, and the same for the staff. We go into all the offices on the wings. We put notices out for the staff. So everyone's aware of what we're doing and when we're doing it. We then look at like creating a flow chart. So that's sort of like the plan of who's going to be in a team, where that team's going to be going, where we're likely looking at getting the most antibodies. So we tend to start off in an IDTS wing and then work our way around the prison. But everyone knows what their role in is, their team, where they're going and who their team is. Do you know what I mean? And then before we start, we always meet up a little in a little hub. We'll have a quick briefing. So everyone's aware of what they're doing and they're happy with the role that they're doing. Do you know what I mean? And where they're going. And then once we finish the testing on the wings, we'll come back. We'll then sort of have a little debrief, look for any lessons learned, anything we need to change, anything that worked really well that we could adapt into it. And then we'll also look at, like, once the testing is finished, we look at a mop-up. So once we've gone round all the wings and offered everyone a test, there always tends to be people that we miss. Do you know what I mean? So then we look at them doing a mop-up towards the end of the week. Because again, some people and anyone who refuses, we'll always go back and just offer them a second opportunity to see whether they want to test. And with that, can I have the next slide, please, Elliot? And I'll pass it over to Christine and Kim. Thank you.
Hi, I'm Chrissy. I'm clinical lead at the prison. So my role was I just wanted to make sure it went as smoothly as possible from a healthcare point of view. And the communication was crucial at this stage. I was involved from the very beginning of the process. I put together the costings that went obviously into the business case, and made sure that everything was ordered in a timely manner. I think from previous hits I've had the feedback that things haven't always been there, like the incentives that we talked about. So it was just make sure that everything was ordered and ready for on the day. I ensured that all the staff were trained on the use of the pop test. We've been started using venous goods for everything, so pop was relatively new. So it's making sure that all my staff were up to date and knew what they were doing with pop testing. And again, I was on the video for the business. So did a briefing with Aaron with their roads around what was going to be happening on the day. Made sure that the staffing, I've got my staffing levels, put towards the flow chart and handed over to Lee in good time, so that Lee put the flow chart going exactly on the day, on the Monday, that what teams are going to be where.
Hi, I'm really sorry. The sound is really distorted. Is there any way? Have you got another speaker there? It's really hard to hear what you're saying.
Sorry, I haven't got any speaker. Yeah, really close to me, so the camera.
Sorry, I didn't hear that.
Yeah. Is this any better now? I've brought the speaker closer.
That's a little bit better. Yeah, thank you.
Oh, perfect. I'll have to just turn my camera off. So yeah, I don't know how much you heard then. So for me, I was in the planning process from the very beginning, ensuring that the communication between the prison and myself and the partners was on point. I did all the costings. I made sure so we completed the business case for all the consumables. I made sure all that was ordered in good time, because previous feedback from other hits had been that things hadn't been there in time. Sorry, I've just noticed on the chat. Can you hear me?
It comes in and out. It's very crackly, and I think on the wider webinar, it's not coming through at all.
Okay. Lee, could you be put for us?
I'm so sorry, you guys. Lee, you're on mute.
Hello. So all the consumables were ordered with 3 months prior. So that's like all the testing kits, the incentives, so I mean everything that we needed to use. All the comms were arranged with Oakwood Media, all the interviews were done. We then looked at staff training for the use of point of care testing. We put a video out on Oakwood TV as well, so all the prisoners would know exactly what test would be getting used, completed by the peers and the FC Trust. Oakwood mainly we utilised every form of communications to encourage everyone in the prison to get tested. And the trolleys and all equipment were all prepped and ready to go. Normally on the first morning of a hit, it's a little bit of organised chaos until everyone gets used to the team, the roles, and what they're doing. Do you know what I mean? And then like everyone gets into the flow to avoid the chaos of a morning, and then it goes in. Can I have the next slide, please, Elliot? So data from the hit. So the population during the hit was 2,099 prisoners. Hep C tests offered was 2,097. One patient was left before we could locate him, and the other patient is currently in hospital, so we couldn't see him. Hep C test completed was 2,011 within 4 days. Population tested during the hit was 96.5%. Population for the last 12 months increased to 97.4% and 98.1% as of the 3rd of the 12th this year. Hep C antibody positives we found was 92. Shepherd tested was 96. Some people were still just finishing treatment, do you mean, and weren't doing SVR, so that's why that number wasn't as high as the antibody positives. And the Shepherd positives we found 5. 3 of these results, so we're still waiting for them. Confirmation from BDST and all come back. They were all negative, and treatment started. So we started 6 by the Friday, 2 new patients that we found and 4 that we've known from recent weeks. And I think that's us. Sorry to rush, but I know we're running short of time. Is that the last slide, Elliot?
Yeah. Thank you so much, Lee. And sorry to Christine. I just got a message. Christine, they are actually in a prison, so it makes it really difficult sometimes. So I'm really sorry. It's such a shame that we couldn't hear clearly, but thank you all very much. And what an incredible piece of work. I mean, it's a huge, I've been on a hit, and it's a huge amount of people to test in a session, you know, over a block of session time like that. I'm going to swiftly move on and just see if we've got a little bit of time. If you guys are still available and don't have to run off, we can run over for 10 minutes just to allow for a few questions. But I'm going to introduce you now to Louise Hansford from HCV later, and she's going to talk a little bit about some of the developments in tackling hepatitis C and drug services. Louise, over to you.
Thanks, Rachel, and thanks to HCV Action for asking me to present today. And like others have said, I just feel really privileged and proud to be a part of this. you know, and Stuart's presentation really took me on a journey that I've been a part of, and just, you know, just that recognition of where we started off. So that leads me nicely onto my first slide, please, Elliot. So what went before? So ahead of the elimination tender and the procurement that Mark and Graham spoke about earlier, all drug treatment providers were commissioned to test for BBVs. However, there was varying commissioning standards and a lack of consistency. So some services were commissioned to just test for antibodies. Some were commissioned to test their intravenous drug users, but not their alcohol users. You know, so there was a real lack of consistency, and what that meant was we couldn't compare one service with another because we were comparing apples and pears. We weren't allowed. So I in partnership with Hep C Trust 10 years ago, I set up Hep C Hants peer-to-peer service down in Hampshire. And at the time I set it up, I wasn't allowed to talk to anybody about what we were doing because it was commercially sensitive. And it was a real shame. And across the country, there were little pockets of innovation. So back 10 years ago, as Stuart said before, we had the direct acting antivirals. You know, there was a lot of support groups going on. There was a lot of people trying to kind of motivate and keep engaged our patients, and also help them with healthier lifestyles to prolong their livers. You know, and along with that, any kind of innovation projects often required like additional funding. And if you're like me and you've ever seen a funding application, it's an awful lot of work for a little bit of money. So it can be really time consuming. Next slide, please, Elliot. So the drug service funded elimination initiative. So you've heard some of those today with my colleagues. So the Hep C, across the drug services, most of the providers were given Hep C coordinators and data analysts to really unpick what was going on in their service and to make targeted action plans. Most of the Hep C coordinators, I think all of them actually, are funded by Gilead, and MSD funds the Cepheid machines and testing kits, and MSD and AbbVie funds some of the Hep C Trust peers along with NHS England. And do you know what? Together, we have just got such a winning combination. You know, like I will always be peer-led, you know, as though, you know, I got goosebumps as Zoe was talking about the impact. You know, never before are we able to kind of come alongside people and make a real difference, and that ripple effect as people benefit from Zoe's support and Lee's support in a prison, and then go out into the community and give back. So yeah, it's phenomenal. So the Hep C later, which I'll talk a little bit in a minute about, has some innovation money for years 1 to 3. And perhaps the biggest, the bit that blows me away is the Hep C Drug Treatment Provider Forum. So this was an initiative that Gilead Sciences pulled together. And as I said, when I set up my project, I wasn't allowed to talk to any other provider. And we've blown that out of the water for the last nearly 3 years. Representatives, so the drug service coordinators, all sit round a table. You know, so you've got Change Go Live, you've got Humankind, you've got We Are With You, you've got Turning Point, you've got WDP, Westminster Drugs Project, you've got Stuart and the Hep C Trust. You know, and you know, and I believe that the Hep C legacy will just ripple on for many years, because we've shown that when we collaborate rather than compete, what we can achieve, you know, it's absolutely been phenomenal. So I'll talk a little bit, next slide, about the coordinator's role. So what our day looks like. So predominantly we were tasked with ensuring that the workforce development, you know, working with service user groups and peer mentors, and something I felt passionately about in my role is making sure every single service had an army of peers that is able to support our guys to get tested, to come alongside them for treatment, and just really keep them engaged. You know, the building the strong and productive professional networks. You know, I was really pleased to go to the national ODN meeting and just look around and see that there's colleagues there that I've now known for a good 5-10 years, you know, all coming together for a common purpose, and it just shows what can be achieved when we work together. You know, as Stuart talked about, like promoting case finding, early prevention, intervention, testing and treatment. Perhaps one of our biggest strengths is using the data at our disposal, if you like, and really using it to do some targeted interventions. And within our working agreement with Gilead, we have a team of patient access to care managers that work across our region. And again, it's just phenomenal when everybody comes together with a common purpose. Next slide, please, Elliot. So the analyst role, so they, you know, as it says on the tin, really. So you know, our hive minds, as I like to call them, they analyse the data that's held at local services, national level. So they look at the data that, so every drug service in the country provides data it's anonymised, pseudo-anonymised data to the National Data Treatment Monitoring System, which is collated and used in reports such as the drug-related death reports. We feed data into the UK HSA shooting up report through the UAM. We feed into the work that Dame Carol Black has done with recovery and reintegration and looking at drug treatment across the field. So there's a whole wealth of data, and actually by coming together and utilising the same data set, we've been able to really get the state of the nation, and the icing on the cake was being part of NHS England's needs assessment work, which we just kind of brought it all nicely together to see where we're at and what's left to do. Next slide, please. So some of the challenges and solutions, you know, Hep C, I'm guessing you're all on this call because you're passionate about Hep C. And there's many of my colleagues on the panel have worked in drug services. Hep C is less than 5% of a bread and butter of a drug service, you know, and we all acknowledge that really, while it's really important for us and there's a lot of time and energy gone into the agenda at the moment, you know, primarily drug services have to keep their patients alive, you know, and I don't mean to sound trivial, but we all know that drug-related deaths is at an all-time high. You know, so there's a lot of pressures, safeguarding, you know, looking after the children. You know, Zoe talked about other health conditions some of our guys incur. You know, like sometimes it's just not the priority all the time for service users, for services, for external agencies. Stuart alluded to something earlier about the changing the culture. So in years gone by, dry blood spot testing for hepatitis C was seen as a nurse-led task. We've really collaboratively turned that on the head, and anybody anywhere like has got involved. And it, you know, when I look at our wealth of data across our own organisation, it really brings a smile to my face that you just got a real even spread now. Instead of 1 or 2 workers in one team, you know, predominantly you've got 95% of staff testing people. I'd be remiss not to mention the COVID pandemic. You know, the COVID pandemic had a lot of benefits within the Hep C agenda because it allowed the peers to do what the peers do best, you know, and they really came into their own, and anybody that was resistant ahead of COVID is no longer resistant because the Hep C Trust guys on the ground, you know, kept the treatment going, kept the testing going. And, you know, I dread to think where we would be if that hadn't happened. And it really, for those that were a bit worried about working with people that had got a history of injecting drugs, who knew, you know, the barriers have come down, and yeah, it's just quite remarkable to see that journey. There has been some services that have been slower to restore, slower to get face to face. You know, every service is struggling with COVID sickness, with home working, with children. You know, I don't need to go on about that point. I guess one of the rubs within drug services is what they're commissioned to do, and the responsibility for post-treatment monitoring. You know, there's ongoing work here to agree and negotiate, because once Graham talked about the reinfections earlier, you know, once somebody's been treated and you need to do a point of care RNA test or a venous draw, you know, that's ends up being quite expensive, and for a drug service that's got not an infinite resource for their BBV testing budget, it can be a bit tricky. You know, at the moment we are really blessed with a fleet of Cefiab machines. We've got a whole family, if you haven't met them, you know, and there's a lot of resources, but one of the pieces of work we're all keen to do is make it sustainable post this initial phase being over. So service user expectations, you know, it's really, really important, you know, as Zoe said, like, you know, the power of that guy, that when Zoe came alongside him and talked to him, you know, absolutely incredible. You know, it's really, really important that we deliver on what we say. You know, we're very, very, most of us, all of us actually, are very busy, you know, but for that one person, you know, like, you don't get a second chance to make a first impression. So next slide, please. So just a little bit about Hep C Later, and the reason I raise this is Hep C Later is an initiative of the NHS Addictions Provider Alliance. We're in a joint working agreement with Gilead and NHSE. Perhaps the unique position of Hep C Later is there's not one single drug service that we're not in partnership with one of the drug services, you know. So today I've been in Hounslow, that CNWL are in partnership with Phoenix, you know. I was in one of our services that were in partnership with We Are With You. A couple of weeks ago, I was in one of our services that's in partnership with CGL, Humankind, Turning Point. You know, so again, you know, I like to think that I've been part of that, bringing everybody together. We're a small team of 8 people. We work across 14 NHS community drug and alcohol services. We have a governance board. We deliver dashboards. We've led on some work to try and increase the quality and the Hep C Later standards. So, you know, it's okay if you can evidence microelimination, but let's have a look underneath that. Social media campaign, webinars, practitioner forums, data forum, newsletter. We are all over social media. If you want to find out more, because I don't want Rachel ringing a bell at me, please feel free to reach out to us afterwards. Next slide, please, Elliot. You know, and as I said, like, these are my colleagues. Honestly, this just blows me away, because, you know, when I worked for Change Grow Live up until 2015, I didn't ever imagine a time where everybody would sit in a room together and be really open about what isn't going well. You know, because we're all very good at going, yeah, aren't we marvelous? But actually, you know, that doesn't, you know, we need to be sharing the blocks. We need to be sharing the learning. And I think collaboratively with the Gilead patient access to care team that work across an ODN, and then the coordinators that work in their services in that ODN, yeah, it's a real winning formula. And I feel really privileged and proud to be a part of that. And collectively, we, you know, the testing, the testing, I think collaboratively last year was over 3,000 tests. So as you can see from our certificate, we were shortlisted in the HSJ COVID Recovery Awards, which again was just a real privilege to just celebrate and acknowledge that with these guys. So next slide, please, Elliot. So microelimination within drug treatment, you can, this has got thingamajigs in, so just press the button, Elliot, please. So what we mean by microelimination is a service-to-service, peer group by peer group approach to achieving Hep C elimination. There's a quote from Jeffrey Lazarus, who, you know, talks about how everybody can come together, and that it's a bit like the recovery agenda. It's contagious. You know, in order to do this, can you press the button a couple of times, Elliot? Top. That's what we need, that's what we've got, and that's what we're achieving. So absolutely, it's really exciting. And next slide, please, Elliot. So one of there's two main pieces of work that have come out of the Drug Treatment Provider Forum. We're about to send out our commissioning standards. They've just been approved this week, but I'm here to talk about the micro-elimination criteria. So prior to us coming together, as I said, when I was talking about the data, we were comparing apples with pears and furthermore conference pairs with other kinds of pairs, you know, so it wasn't a level playing field. And for people that such as our colleagues in ODNs, when they were looking at this data, it was really tricky for them to see the wood for the trees and understand what they were looking at. So collaboratively, we've agreed that 100% of clients in structured treatment are offered a Hep C test, you know, and there's a recognition that people may refuse, and, you know, there aren't many people that if the offer's made correctly and with enthusiasm, you know, that actually refused. You know, I think in over 10 years of working with Hep C, I've only ever had one guy refuse, and it wasn't the test he was refusing. He didn't want the results. You know, typically for me, I persevered, and on the third time of asking, we got him tested. And of course, he had Hep C. You know, he's been successfully treated. There is an expectation that 100% of those with an in-history of rejecting have been tested. And again, similarly to what I've just said, you know, if the offer's made right and it's made with care and compassion, non-judgmental, no stigma attached to it, you know, this is something that we want to offer you to support you. You know, it's not rocket science. There's an expectation that if there are ongoing risks of transmission, so if service users are actively sharing drug using paraphernalia, you know, that we would continue to offer those guys a test. You know, this is quite, and I won't get into the nitty gritty, but there are now ways that we can make sure that we are testing the right people at the right time. You know, so what collaboratively we've agreed is that if Zoe comes into me and says, "Oh, Louise, I haven't used for 6 months. I'm doing really well. I've got rid of all my phone numbers. I've detached from my peer group," and I convince Zoe to have a test. Fundamentally, I'm saying to Zoe, I don't believe her. You know, because if somebody genuinely doesn't have any risk factors, why would I want to test them? So collaboratively, we've agreed that we're gonna, you know, start focusing on the people that really need a test. And my colleagues at UK HSA would be really pleased about that, because we need to make sure we've got robust surveillance and prevalence data. And then 90% of Hep C positive patients have commenced treatment. And again, this is where NTDMS, so our recording system across drug treatment, doesn't actually record that info. So we are reliant on that good communication, the pathways that Stuart spoke about earlier with our ODN colleagues. There is a complete slide set that goes with this slide. So if any of you, again, would like it, my email's at the back and we can get that over to you. Next slide, please, Elliot. So this is, oh. So basically this just shows you the cycle, you know, so it's basically review, monitor, assess, declare, you know, like you know, this is about kind of the micro elimination. So each month, every drug service provides Gilead or Hep C later, which is a partnership with Gilead, data. So we have a nice visual on where they're at. You know, I've done a piece of work with one of our services that declared micro elimination in the summer. Thurrock. They literally had 2 people that are new in service that changed their micro elimination dashboard. You know, the minute I email them, they've got those people in and got them tested. You know, it's something that services are really taking pride on in these really challenging, difficult times when everything's a priority. For a service to get a micro elimination status, they really want to maintain it. They really want to do the best by their service users. So again, there is some slides that go with this. And then next slide, please. Hopefully I'm doing all right for time. So the drug treatment BBV standards, so it's ongoing work. It has just been ratified and authorised. So you know, we want to ensure that the work that all of us have done collaboratively is sustained. And in order to sustain that, when some of us move into other posts or go back to our substantive roles, and MSD think they're getting their caveat machines back, that, you know, we need to make sure that what we've done is sustainable, that everything, or that services are in a good state. You know, so we're encouraging commissioners to look at having BBV leads, to having test and treatment. You know, Helen Hampton at We Are With You has done a big piece of work previously, and CGL are now doing that a similar piece of work about nurses being involved in the pre-assessments. You know, blue sky thinking moving forward. We want our non-medical prescribers to be able to act really swiftly. Across the country, we've got, you know, Jess in Bristol does all the pre-treatment assessment. You know, we've got our highly skilled nurses in place. You know, so it's just about continuing to invest in those guys, develop their role, and just so that we can act really swiftly. And I think Graham spoke to this earlier about the need for robust needle exchange and harmonisation offers. It has really, really slipped off the agenda. It's the only way we're gonna sustain and get to elimination. And I think that's my last slide. Elliot? Lovely. Thank you. And hopefully I did all right for time.
Perfect. Thank you so much, Louise. I'm really conscious of the fact that we've gone way over time now, and we do have 5 minutes just to, I think probably we've answered the questions in the Q&A box. I want to say thank you very much to all our speakers. Unfortunately, Mark has had to leave now as well. He had a meeting at 4:30. But perhaps before we go, a quick whistle around the panel, just I guess we can either go. Let me do. I've got 2 questions here, 2 things. So maybe Zoe, what lessons? What do you think has been the key to the success of the elimination deal?
Partnerships.
Yeah.
Everyone working together.
Yeah, I'd always go for partnerships as well. Lee, what about you? What do you think the key has been? You're on mute.
I think the partnership, but the passion of the people we work with. Yeah. So go that a step above and beyond to make sure we are getting people through treatment. It also blows me away on a daily basis.
Yeah, and I think that's been evident in all the presentations that we've had today, this afternoon. That's been really evident. Stuart, what lessons from the Hep C elimination programme would you highlight to other healthcare professionals?
Oh, well, I think that I'm obviously going to say the value of peers, lived experience. I saw someone in the chat talking about maternity care, and I did actually meet someone who worked with very young mums who then went back to talk to expecting mums in the first or second trimester of their pregnancy. And so in that respect, that is a peer model as well. And I think, you know, the learning is that, you know, there are people in the community, and especially with our group, where volunteering is part of their step back to society. And, you know, you might even say that about women who take time off for work, who want, you know, don't want to come back full time, but would like to volunteer. I mean, you could expand a peer model across a broad range of healthcare, and it's about, it just comes back to that partnership. Once the clinical teams accept you as part of their team, then it really puts a really strong offer together for patients out in the community.
Yeah, absolutely. And Louise, I'd put the same question to you, Louise, before we finish. What would you highlight from the Hep C elimination programme?
I think for me, it's when we all work to our strengths and we all bring our bit to it, you know, what we can achieve. I mean, do you know what? It's absolutely phenomenal. I mean, when I think back to like the patients that collectively we've had a hand in treating, every one of those is somebody's son or daughter. You know, we've broken down stigma by we've made it okay to be an injecting drug user with Hep C. We've made it okay to have Hep C. You know, and I just think the knock-on effect for this, there are so many other areas that we, you know, naloxone, needle exchange, drug-related deaths. Look at what we've achieved here and roll it out. And the lived experience, you know, it's the icing on the cake, isn't it? So yeah.
Absolutely. We just got a quick question that's come in, and actually I'm just going to go with it, because it's how can we target increased testing and knowledge for other groups of people such as migrants and asylum seekers? Well, we're actually doing it. So I guess that's the answer to that question, is we are actually doing that now and have been for a little while. Our prison team are working in the IRCs. We do work with migrants. It's only just started in terms of migrants. We do a lot of South Asian work. We're expanding out with the Eastern European work. So yeah, we're doing it. It's another group. There's another risk for hepatitis C. So I guess, I mean, it leaves me to say thank you very much for all of you that have managed to stay on, because we've rolled over. Thank you to all our speakers. As you can tell, there has been so much enthusiasm, which is what it's really hard to keep people to time when we're talking about this. It is a globally unique program, and I do a little bit of work globally, and yeah, people are amazed when they see our program of work. The fact that we have this really innovative initiative that has brought together many stakeholders that work really closely together, from pharmaceutical companies to NHS England, to substance misuse drug service providers, to patient organisations. And the core to all of it has very much been the partnership working. And it's quite incredible. I guess it's about watch this space. And also think about, you know, what legacy do we leave behind? You know, we have within this program found a way of working with groups that are by and large excluded from health or sit outside healthcare systems. Where can we take it next? Everybody's starting to say goodbye. Maybe that's another webinar for us. Maintenance. You know, what do we do for maintenance? Where do we take this next? Where's the lessons that we take forward? I mean, we've got a lot of ideas. I'm sure all of you have too. And maybe that's what we do our next webinar on. Please will look out for the report, which is due out in January, where there'll be much more detail around each of the initiatives, the programs, the initiatives that have been launched, but also around the background of the program and feedback and input from each of the partners. So I wish you all, I should say season's greetings. I don't want to say happy Christmas, but season's greetings. I'm not a Christmassy person personally. It's for the kids. Thank you all so much for joining. It's been, yeah, just heartwarming. And thank you very, very much. And we'll see you again soon. Thank you and goodbye.